Good afternoon. My name is Jackie, and I will be your conference operator today. At this time, I would like to welcome everyone to the VAE Educational Webinar Conference Call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, please press the pound key. Thank you. Kathy Maffrey, you may begin your conference.
Thank you. Welcome to the Quality Improvement Organization Network webinar for the Quality Improvement Organizations, hospitals, and the many partners to support reducing ventilator-associated events across the country. My name is Kathy Maffrey, and we have almost 500 people from hospitals joined today or registered to join, including Puerto Rico. So we know we have a vast audience out there anxious to get started on ventilator-associated events and see what we can do to reduce them. A couple of housekeeping items. We want to let you know that questions, the speakers requested that they get logged through the NHSN help desk, which we will be providing the link in the chat shortly. That way they can track them and make sure they get the correct answers to the correct people. And the handouts for today and the recording will be available on Healthcare Communities, which will be later, and that link will also be shared in the chat. And to kick us off today, we have Anita Thomas, the CMS QIO Patient Safety Lead at CMS. So Anita, I'm going to turn this over to you.
Thank you so much, Kathy. Hello and good afternoon. This is Anita Thomas. I want to welcome everyone to this call and thank you for your work and dedication to making care safer and improving the quality of care for our patients and their families. We have a great session today on ventilator-associated events. As you know, ventilator-associated events, or VAE, are serious events such as ventilator-associated pneumonia, or sepsis, for example, that can lead to severe disability and or death. Our work together collaboratively through education, training, and the use of data and other innovative methods can reduce these events. For our learning session today, I want to introduce Cindy Gross. Cindy is an infection preventionist with the Centers for Disease Control and Prevention, CDC, Division of Healthcare Quality Promotion Surveillance Branch, where she is a member of the NHSN Protocol and Training Team. In this role, she provides consultation and technical assistance regarding surveillance for healthcare-associated infections using NHSN. Cindy serves as the subject matter expert for VAE and the VAE calculator. She has 30 years combined experience in healthcare and the local and state public health sectors. She has worked as a public health communicable disease epidemiologist, an infection preventionist, and medical technologist. Cindy has her Bachelor of Science degree from Indiana and from the University of Pennsylvania. She has a specialty in microbiology and is certified in infection control. She is a published author in the field of infection control. So I want to warmly welcome Cindy. I'll turn it over to you.
Thank you for that nice, warm introduction. It's a pleasure to join you all today. We're going to cover VAE today. As you had expected, we're going to review ventilator-associated events and definitions and surveillance methods. And also going to cover some important changes that were made to VAE surveillance and the pneumonia and VAP definitions in 2015. And as I understand to be scheduled, we will rejoin or come back together at a later date and we'll discuss some case scenarios and review the ventilator-associated calculator. So let's get started. A little background. As you know, ventilator-associated pneumonia, or VAP, is an important complication of mechanically ventilated patients. But of course, it's not the only adverse event that occurs in critically ill patients who require mechanical ventilation. And there really is no valid, reliable definition for VAP. whether we are talking about definitions used in public health and surveillance, clinical research, or even bedside diagnoses and the clinical care of patients. We need more accurate diagnostics for there to be a definitive definition, but until that time, we still have the need to conduct surveillance for complications in mechanically ventilated patients and track prevention progress. The pneumonia VAP definition, the traditional way that we've tracked ventilator-associated pneumonia in NHSN, includes many subjective elements, as I'm sure many of you are aware, and the definition is neither particularly sensitive or specific for the clinical condition of ventilator-associated pneumonia. Then this is particularly challenging in an era where we have public reporting of healthcare-associated condition rates and where we're comparing among facilities, and there is pay-for-performance programs incorporating some of these conditions into the monitoring. So with these issues in mind, we set out here at CDC to modify the approach to ventilator-associated pneumonia surveillance to achieve face validity or clinical credibility, to improve the reliability of the definitions, and to reduce the burden of surveillance. So a new approach was finalized and implemented in January of 2013, and VAE at that time replaced in-plan VAP for patients greater than or equal to 18 years of age. And as the chosen name reflects, it is not a clinical diagnosis. VAC refers to a ventilator-associated condition, IVAC refers to a complication, and PVAP refers to possible VAP. This being a new approach, when we released it in 2013, we did anticipate that there would be adjustments made to the protocol, and there was. In part, these changes were based on feedback received from users, and we do value the information that you all provide back to us, and we do listen. In 2013 and 14, the following adjustments were made to the protocol. We modified the interpretation of PEEP criterion such that the daily minimum PEEP values of 0 to 5 centimeters of water were changed to be considered equivalent when you're making a VAC determination. And this was to address concerns related to VAC detection due to provider weaning preferences and in some selected clinical situations. So to make it correlate more accurately with what was being seen clinically. Age-based surveillance approach, when VAE was first rolled out, those patients that were greater than 18 years of age were the ones that were eligible for VAE surveillance. And this was changed to location-based surveillance in 2014. And that fell in line more so with all our other NHSN surveillance definitions. So a patient is eligible for VAE surveillance now, not based on their age, but based on the location in which they are housed. An additional requirement that was added in 2014 was the need for the daily minimum PEEP and FiO2 value to represent a setting that was maintained for at least an hour. And then also in 2014, we introduced some alternate means of meeting the purulent respiratory secretion definition, and that was to accommodate the many different laboratory reporting formats that are found across the country. And then finally, we did adjust and refine the antimicrobial agent list. So beginning in January of this year, we have 4 additional modifications that were introduced. And the first of these has to do with the third tier of the VAE algorithm. The tier was consolidated to represent one specific event. With this, there was just a slight realignment of how the third tier definition can be met. And PVAP replaced the original possible and probable VAP definitions. PVAP uses the same parameters, so we're still looking at culture results, the ability to meet the purulent respiratory secretion definition, and then some non-culture-based testing that allows for the PVAP definition to be met. This modification was set out to provide simplification, and it is still consistent with the plan for analysis in that we never intended for there to be analysis for the individual possible and probable VAP. It was going to be combined as one event. The second modification in 2015 to the VAE surveillance protocol was to further provide some further clarification to the daily minimum PEEP and FiO2 when we are requesting that that value be maintained for at least an hour. And this modification applies when there's no value throughout the calendar day that was maintained for at least 1 hour. And in that situation, then the very lowest value set on the ventilator for the calendar day is selected. So some examples of when this might take place is if the ventilation is initiated late in the calendar day, they may only have 1 or 2 readings and none of those readings have been maintained for an hour. Or conversely, they are removed from the ventilator early in the calendar day and there's only a single or just a couple readings, and again, not one that was maintained for a full hour. And then the final scenario where this might come into play is when ventilator settings are just changed frequently throughout the day such that there's no setting maintained for an hour. The third modification was an addition to pathogen exclusion lists. The following are not available for use in meeting the PVAP definition: Cryptococcus, Histoplasma, Coccidioides, Paracoccidioides, Blastomyces, and Pneumocystis. These are community-associated fungal pathogens that are either not known to or rarely have been known to cause healthcare-associated infections. So you can no longer choose one of these pathogens to meet the PVAP definition. And in fact, when you're in the application entering a PVAP into the NHSN application, these pathogens would not come up on the drop-down for you. And then the final modification is not really a modification. It's actually an addition to the protocol, and this is an addition of a new denominator called episodes of mechanical ventilation, or EMV. Reporting this denominator in 2015 is optional, and what the denominator represents will be the total number of episodes that occur in a location during the month. Evidence-based practices that improve outcomes in ventilated patients focus on getting the patient off the ventilator. So we need to explore the use of other denominators with this new surveillance method, and this is the first step in that direction. So you still are required to report ventilator days and APRV days when conducting in-plan VAE surveillance, but the reporting of episodes of mechanical ventilation is an option. So to summarize the changes made that summarizes the changes made in 2015 to the VAE surveillance. And this is a good time to review what lower respiratory events are available related to a patient's location and related to in and off plan use. This is an area that generates many, many questions. So first, let's talk about VAE. VAE, as you see here in the snapshot of the event that's located on the website, is for in-plan option only for ventilated patients in adult units. PVAP, or Ventilator Associated Pneumonia, is the only plan that is an option for ventilated patients in pediatric locations. And note that as of January 2014, in-plan neonatal VAP surveillance is no longer available for use. So that being said, the pneumonia definitions are still available for off-plan surveillance for ventilator-associated pneumonia in adults, children, neonates, and they're also available for those patients that are not ventilated, to include adults, children, and neonates. And they are also available, and this is the big question that comes up a lot when you're doing Class C for surveillance. and you're trying to determine if a bloodstream infection is actually secondary to another site-specific infection. Now, the pneumonia definitions in 2015 are now only found in Chapter 6 of the NHSN manual. And you'll note that we've changed the title of the chapter to more accurately reflect the use. So it's pneumonia, and it's for ventilator-associated pneumonia and non-ventilator-associated pneumonia, or just new events. So, the million-dollar question. Can I use the pneumonia definitions to assign a secondary BSI when doing Class C surveillance? And the answer is yes. So any time that you're trying to assign a bloodstream infection as secondary to another primary site of infection, you have to meet the NHSN site-specific infection definition, and that would include definitions found in Chapter 17, the pneumonia, the UTI, or the VAE surveillance definition. And then for all of those events, with the exception of VAE, you would apply the guidelines located in Appendix 1, the secondary BSI guide in Chapter 4 of bloodstream infection event. And there are two ways in which a bloodstream infection can be determined to be secondary. It's either a blood culture that is used as an element to meet the site-specific criterion, or the blood and a site-specific specimen culture, and that would be a site-specific specimen culture that's used to meet the infection criterion, must match for at least one organism. Of note, do recognize that secondary bloodstream infections can only be reported for a NEU2 or a NEU3 specific event. So just to highlight, these are the ways you can meet a secondary bloodstream infection. So let's look at how that's done with pneumonia when we have blood culture as an element. You'll see that the blood culture collection date has to occur in the 7-day infection window, and it is available for all pathogens with the exception of the excluded pathogens. That would be Candida species, Enterococcus, and Staphylococcus species. The second way to meet a BSI secondary to pneumonia would be if the blood culture and the site-specific specimen culture that is used to meet the infection criterion has a match for at least one pathogen. Eligible site-specific culture collections must occur in the 7-day infection window period, and the specimen must be ineligible. This is another big question. A sputum culture is not an eligible specimen for meeting pneumonia 2, and in fact, there's a footnote that refers to this. It's footnote number 9. The specimens that are available for meeting this particular element of the NEU2 definition would be a minimally contaminated specimen, a BAL, a protected specimen brushing, pleural fluid, or lung tissue. And you'll note that while the element says positive quantitative culture, we know that many laboratories do not report these specimen culture results quantitatively. And in that event, you can use the semi-quantitative equivalent, which is highlighted at the bottom of the slide, and basically is saying that a semi-quantitative equivalent amount of moderate or heavy growth, or 2+, 3+, 4+ growth, is considered to correspond to those quantitative amounts. Sputum, a little bit more on sputum. I said that you can't use that to meet your NEU2 definition. Sputum specimen is only useful when the patient is immunocompromised, and that refers to footnote number 10 of the pneumonia algorithms, and when the blood and the sputum or endotracheal aspirate are both growing a Candida species. Okay, so when should I use the pneumonia VAP definitions instead of VAE? Never. When conducting in-plane surveillance, when surveillance is conducted for healthcare-associated pneumonia that is not associated with mechanical ventilation, or when determining if the BSI is secondary to lower respiratory sites, or B, C, and D. Excuse me. And the answer is B, C, or D. All right. So that being said, let's just continue on with pneumonia and VAP and talk about the changes for 2015. In 2015, the pneumonia VAP had a couple modifications as well. Purulent sputum is determined by direct gram stain, and this is needed because laboratory confirmation of the clinical description of purulence is laboratory confirmation is required since written clinical description of purulence is highly variable. So we're basing the meeting that definition on a gram stain result. The second change for pneumonia was pathogen exclusions for meeting pneumonia and VAP, and these mirror the VAE protocol in that Candida species or yeast not otherwise specified, Staphylococcus species, and Enterococcus species are excluded unless isolated from lung tissue or pleural fluid. And likewise, the fungal pathogens are not available for meeting a pneumonia VAP definition. The third modification was that pathogen reporting and secondary bloodstream infection attribution for new one definition is not permitted, and this is not a modification to the definition, but it is a modification to the application. New one was always considered to be a clinical pneumonia. You did not have laboratory results, so therefore you cannot have a secondary BSI associated with pneumonia 1. So that takes care of modifications for VAE and the pneumonia VAP definitions. And I know this is a presentation based on VAE, but it cannot be done without talking about VAP because the definition is still available. Primarily for use in pediatric locations, but you also use it when you're doing your CLABSI surveillance. Okay, so let's move on to VAE. Before getting started, just a reminder that the guidance that's identified in used for identifying HAIs in Chapter 2, that's used, for example, for CODI, CLABSI, that does not apply to VAE. The definitions described in Chapter 2 are not to be used for VAE. Okay, so who is eligible for VAE surveillance? Inpatients of acute care hospitals, long-term acute care hospitals, and inpatient rehab facilities. Patients in adult locations are eligible for VAE surveillance, and this would include pediatric patients that are housed in an adult location that is included in VAE surveillance. Adults in pediatric locations would be included in PVAP surveillance. So just to draw your attention to the fact that VAE and PVAP are location-based. Now, when you have a very young child, and this doesn't happen often, but there are some facilities where this may occur, a very, very young child that's not thought to be physiologically similar to an adult that is housed in an adult ICU or a ward location where VAE surveillance is taking place, you would not include that tiny child or the child that's not physiologically the same. They would need to be covered using PVAP surveillance, and if necessary, you would just create a virtual location. Who's not eligible for VAE surveillance? That would be patients that are ventilated less than 3 days, patients on high-frequency ventilation or extracorporeal life support, and these patients are not included in VAE surveillance only during the times that they're receiving those therapies. So just because you have a patient on high-frequency ventilation for 3 days, that does not exclude them for the rest of their duration in a setting where VAE surveillance is being conducted. It's just during the period of time while they're on that excluded mode of ventilation. Also, I want to point out that patients who are receiving conventional mechanical ventilation and also receiving therapies such as prone positioning, nitric oxide therapy, helium-oxygen mixture, or epoprostenol therapy. They are included. They're on a conventional mode. They would be included in VAE surveillance. And then in addition, just to review our patients that are on APRB, they are also included in Ventilator Associated Events surveillance. It is just that your back determinations would be made using the FiO2 parameter, again, during the periods of time when the patient is on APRB ventilation. So a little bit more information on APRB. What is it? APRB, and I do not profess to be a respiratory therapist, so this is a definition taken strictly from provided by somebody who does know what APRB is. It's a mode of mechanical ventilation characterized by continuous application of positive airway pressure with an intermittent pressure release state. And this mode of ventilation is used in patients with acute lung injury and acute respiratory distress syndrome. And it also can be employed for use after major surgery to treat or prevent atelectasis. Some other names that you may run across in charts when you're reviewing for surveillance for VAE, you may run across bilevel, bivent, biphasic, PCD plus, or duopath. What I recommend that you do is that you reach out to your respiratory care and respiratory therapy or critical care departments and find out if this mode of ventilation is used in your facility, and if so, how would you determine during chart review that the patient was on APRB, and how would you determine how many APRB spent days you're going to be capturing. So while a patient is on APRB or similar modes, and if they're included in VAE surveillance, it's important to note that the evaluation for a VAC will be limited to the FiO2 parameter. And again, this is when the patient is on APRB. So if a patient is on APRB for the entire calendar day, when it comes time for you to determine the daily minimum values for that calendar day, you would not be using PEEP. You would just disregard PEEP. You would only determine a daily minimum FiO2 value. So if you find documentation in a chart of a high-low value, that's not to be used for PEEP. And also, you would not designate PEEP for that calendar day as 0, or if you're using the VAE calculator, you would not enter 0 into the calculator. You just would not have a value for PEEP for those days. Now, if the patient is on APRB for portions of the calendar day, when you're doing your determination of the daily minimum PEEP and FiO2, you would utilize the PEEP values that were recorded during the periods of time when the patient was on a conventional mode, and you could select a daily minimum PEEP value for that calendar day for those patients. So now that we've talked about who's eligible and who's excluded, if a patient is admitted with a community-acquired pneumonia, they are excluded from VAE surveillance for 14 days. Is this true or false? Well, the answer is false. And the reason that is all patients who are eligible for VAE surveillance are to be included in VAE surveillance. There's no exclusion for specific admitting diagnoses or underlying illnesses. And remember that the present on admission definition that you find in Chapter 2 does not apply to VAE. The algorithm requires that there's a period of stability on the ventilator and typically should not be capturing events that represent ongoing worsening. So if you have a patient who's admitted with, for example, community-acquired pneumonia, and they stabilize or they improve on the ventilator for 2 days, and then there's worsening that ends up meeting the VAC definition, it's possibly an indication of a new ventilator-associated event. And we know that patients with CAP may truly experience complications related to mechanical ventilation that are preventable, and we certainly wouldn't want to miss the opportunity for improvement in those patients. Okay, so let's move on now and just run through the algorithm itself. I have about half an hour left here, so we're going to go at breakneck speed. I do want to emphasize that VAE is a definition, the VAE definition algorithm is a surveillance definition, and it is not meant for clinical definition algorithm. It's not intended for use in the management of patients. So here we have a depiction of the summary of the VAE definition algorithm, and you can see that there are 3 tiers, VAC and IVAC in bright yellow, and the PVAP definition in the lighter yellow. And the key feature of VAE is that there is no need for chest x-ray information, which causes much consternation when you're trying to figure out if your patient meets a pneumonia definition. Before we get started with running completely through the algorithm, I do want to review a few of the key definitions that VAE utilizes. And the VAE protocol does use the ventilator definition that has been in place and used for ventilator associated pneumonia surveillance. A ventilator is defined as a device to assist or control respiration inclusive of the weaning period through a tracheostomy or endotracheal tube. And do note that these modes of ventilation listed, intermittent positive pressure breathing, nasal positive and expiratory pressure, and continuous nasal positive airway pressure, they're not considered a ventilator use unless they are delivered via tracheostomy or an endotracheal tube. So the patient who's on CPAP with a mask obviously is not a ventilator patient. Second definition to cover is episode of mechanical ventilation. This is defined as a period of days during which the patient is mechanically ventilated for some portion of each consecutive day. A break in mechanical ventilation of at least 1 full calendar day, followed by reintubation or reinitiation of mechanical ventilation during the same hospitalization would be a new episode. So if a patient is on and off a vent during a calendar day, that is considered one continuous episode. Or, for example, if the patient is extubated today and then reintubated tomorrow, that would still be considered one episode, as there was not a full calendar day break from ventilation. But if the patient is extubated today, remains off the ventilator all of tomorrow, and then is reintubated on Friday, the reintubation on Friday would begin a new episode of mechanical ventilation. And the reason I'm stressing this is that that would mean as that new episode of mechanical ventilation, you now need to, in order to meet a VAE definition, you need to establish a new period of stability or improvement followed by a new period of worsening oxygenation. So with that break of a full calendar day in between, you can't use a period of stability that occurred on Tuesday and Wednesday, then you have a break on Thursday, and now you go, oh, wow, now the guy's got a worsening oxygenation. That break of 1 full calendar day means you start over with your VAC determinations. Now, the VAC definition, the first level of the VAE algorithm, is identified by the observance of deterioration in the respiratory status of a patient after a period of stability or improvement. This baseline period and subsequent deterioration are determined based on changes in daily minimum PEEP and FiO2. This is not determined by how the patient looks clinically. So what we want to do is take a look at what PEEP and FiO2 actually are referencing. PEEP is a technique used in respiratory therapy in which airway pressure greater than the atmosphere pressure is achieved at the end of the exhalation for the introduction of a mechanical impedance to exhalation. And that's according to Stedman's Medical Dictionary, not according to Cindy Gross. In patients on a conventional mechanical ventilator, PEEP is one of the parameters that can be adjusted depending on the patient's oxygenation needs. And for the VAE algorithm, a sustained increase in the daily minimum PEEP of greater than or equal to 3 centimeters of water, followed by a period of stability or improvement on the ventilator, is one of the 2 criteria that can be used to meet the VAC definition. The second means of meeting the VAC definition uses the FiO2, or the fraction of inspired oxygen. And this is strictly referring to the fraction of oxygen in inspired gas. So, for example, the FiO2 of the room you're sitting in is around 21% or 0.21. In patients on mechanical ventilation, the FiO2 is another of the key parameters that can be adjusted to meet their oxygenation needs. And for VAE, a sustained increase in the daily minimum FiO2 of greater than or equal to 0.20 or 20%, followed by a period of stability or improvement on the ventilator, is the second of the two criteria that are used to meet the VAC definition. So definitions aside, let's now walk through the algorithm tier by tier, and we'll start at the top, focusing on the first tier, VAC. The patient must be on a mechanical ventilator for greater than 2 days to be eligible for VAE surveillance, and they must have a baseline period of stability or improvement followed by a sustained period of worsening oxygenation. This is just a screenshot of what everything looks like in the algorithm or in the protocol. A point to remember is that if the baseline is established in the FiO2 parameter, the evidence of worsening oxygen must occur in the same parameter. So the point being, you cannot meet the VAC definition because you've observed stability in FiO2, but then you're noticing that the PEEP has been cranked way up. So the worsening of oxygenation must be relevant to the baseline period established in the same parameter. The VAC definition is the foundation of the VAE algorithm. It's a progressive algorithm. So we're going to break this tier down piece by piece and make sure you fully understand how the VAC definition is determined. So first, let's look closely at daily minimum values. We've defined PEEP and FiO2, but what are we talking about when we say daily minimum FiO2 and PEEP? It's important that you have a good understanding of what these values are and how to make the daily minimum value selection accurately. So when a patient is ventilated, the FiO2 and PEEP ventilator settings are documented across the calendar day, and that is what is used to determine the daily minimum FiO2 and PEEP. You'll find the FiO2 and PEEP settings that are documented across the day, typically recorded in the paper or the electronic medical record on either the respiratory therapy or the nursing flow sheet. And as all surprises, it will probably be found in the section that pertains to the respiratory status of the mechanical ventilation. Remember that you're going to be using a calendar day, not another capture period or another designated 24-hour period when you're determining the daily minimum FiO2 and PEEP for each calendar day. From those documented settings, you'll choose the lowest FiO2 and PEEP setting during the calendar day that was maintained for at least 1 hour. As discussed earlier, if there's no value that has been maintained for at least 1 hour, then you'll simply select the lowest value available, regardless of the period of time in which the setting was maintained. And again, just a reminder of some of the times where this exception may have to be used. Keep in mind when you're choosing the daily minimum PEEP and FiO2, you use all settings while the patient is on an eligible mode of ventilation. So this includes settings collected during weaning and mechanical ventilation liberation trials, as long as the patient is ventilated. So of course, you wouldn't include trach patient who is only receiving supplemental oxygen through the trach tube, but if they are connected to the ventilator and using ventilator support, you would be including them in your VAE and selecting a daily minimum FiO2 and PEEP. When a patient is on APRV, just a reminder that you'll only be selecting the PEEP when they are not on APRV. So some exceptions and exclusions. Again, periods of time when a patient is on high-frequency ventilation or extracorporeal life support, you'll be disregarding the documented FiO2 and PEEP, and periods of time when the patient is not receiving mechanical ventilation support. You won't be using any documentations in the chart. And then again, when the patient is on APRB, you'll only be reviewing the FiO2 data. So let's take a look at a few examples of the documentation you may find, and then how you would select the daily minimum values. So in this example here, the mode of ventilation is assist control ventilation, which is a conventional mode of ventilation, and it's documented 8 times over the course of a calendar day. The FiO2 and PEEP settings are available for you, and when the documentation of the settings takes place, the intervals of greater than 1 hour, as in this case, they're documented every 3 hours, it's easy to determine which values have been maintained for at least an hour. So in the example, the daily minimum values for this calendar day are 0.70 for FiO2 and 5. It's simply the lowest values documented on the calendar day. Guidance for determining when the daily minimum PEEP and FiO2 settings are recorded for less than an hour intervals are found in the protocol, and there must be sufficient documentation of consecutive readings to meet the minimum required duration of 1 hour. When settings are documented less than an hour, you do want to follow this guidance. So, for example, if there's tracking every 15 minutes, you're going to need 5 15-minute increments to determine 5 consecutive readings to determine that the value was maintained for 1 hour. This is a standardized method of determining the hour maintenance, and it's important that all users follow this guidance. So in this example, there are periods of time when the values are documented on an hourly basis. So it's important to choose the value that was maintained for at least 1 hour. Following the protocol guidance, in this example, the daily minimum PEEP is 8, and the daily minimum FiO2 is 0.75. You'll note that 0.70 is the lowest FiO2 value for the calendar day, but it was not maintained for an hour. At 3 a.m. it was at 0.70, but at 4 a.m. it was recorded at 0.80. So sometime between 3 a.m. and 4 a.m. it changed, therefore it was not maintained for a full hour. Let's look at an example when there may not be a time frame in which any value has been maintained for at least an hour. In that example, you will simply choose the lowest value documented. No value is maintained for at least 1 hour. So in this example, we have on Monday no time in which the value was maintained for a full hour. So the value is just simply for Monday, the calendar day Monday, would be 8 and 0.70 for the FiO2. Patients intubated at 2 p.m., another example, PEEP and FiO2 are set at the following values for the remainder of the calendar day. What's the daily minimum PEEP and FiO2? In this example, the PEEP, daily minimum PEEP is 5, and the FiO2 is 4. Another example, patients intubated at 6 p.m. PEEP and FiO2 are set at the following values for the remainder of the calendar day. What are the daily minimum PEEP for this calendar day? In this example, the correct answer would be 5 for PEEP and 0.60 for FiO2. You'll note that 0.40 was the lowest value for FiO2 at 8 p.m., but again at 9 p.m., as in the previous example, it's bumped up to 0.5, and sometime between 8 and 9, it was moved. Therefore, we did not have maintenance of that value of 0.40, so we move on and look for the next lowest value, which was 0.6, and we do have maintenance of that between 10 and 11 p.m. So in general, when you're selecting the daily minimum PEEP and FiO2 for each calendar day, you want to choose the lowest value that was maintained for at least 1 hour. So these values are collected and recorded and evaluated then to determine if the VAC definition is met. They're used to assess for both the period of stability or improvement and the period that indicates worsening of oxygenation. And remember, you will not be comparing values that occur within a calendar day to determine stability or worsening. You're comparing across the calendar days. And just a reminder, that upon making the daily minimum PEEP determination, if the value ends up being a value between 0 or 5, whether making determinations manually or using the VAE calculator, the PEEP values of 0 to 5 are all considered to be equal to 5. Okay, so we've reviewed the daily minimum value concept. Now let's make sure we have the baseline and worsening concepts of the VAC definition fully understood. The patient has for a period of stability improvement, the patient has a baseline period of improvement or stability on the ventilator, and that's defined as greater than 2 calendar days of stable or decreasing daily minimum FiO2 or PEEP. After that period of stability or improvement, the patient has at least one of the following indicators of worsening oxygenation: either an increase over the daily minimum baseline of greater than 20 points, greater than or equal to 20 points, that's sustained for 2 calendar days, or if you're looking at the PEEP value, it has to be an increase greater than or equal to 3 centimeters over the daily minimum PEEP in the baseline period, and it must be sustained also for greater than 2 calendar days. So let's look at some examples. Here we have an example of what is a baseline period of stability. We have FiO2 values of 30, followed by an increase greater than or equal to 20 over the baseline period, so the VAC definition is met. Another example, this would be an example of baseline period of improvement. We go from 35 to 30, and again, an increase over that baseline period greater than 20 points, so the VAC definition is met. In this example, just demonstrating that although we have this bump up to 70, note that there is no baseline period of stability or improvement. The values immediately preceding that worsening oxygenation do not represent stability or improvement as the values are increasing. So in this example, have we met the VAC definition, focusing on the PEEP parameter? And the answer is no. The increase over the baseline must be relative to both days of the baseline period. You have a baseline period of improvement. In mechanical ventilation day 2 and 3, we improved from 7 to 5. And then relative from day 3 to 4, there's an increase of 8, which is greater than 3, which is equal to 3 centimeters of water. However, in comparison to the first baseline day, it's only 1 centimeter of water. So the VAC definition is not met. Let's look at this example. What if there's an increase for 1 day and then a decrease? Well, we have a baseline period of stability on days 2 and 3. We bump up 3 centimeters over the baseline period on day 4. But then the PEEP is decreased to 7, and that again does not provide the means of meeting the VAC definition. The VAC definition is not met because that increase was not sustained for greater than or equal to 2 days. Okay, how about in this example, VAC or no VAC? Again, we have an example here where we have an increase over the baseline, but then the value falls down to 8. Does that meet the VAC definition? And the answer is yes. Even though the value dropped, it was on day 5 from 10 to 8 in the PEEP parameter, it still is greater than or equal to 3 centimeters of water over the baseline period. When you have this discrepant changes, PEEP going up and FiO2 goes down, keep in mind you only need to meet the VAC definition in one parameter, and so VAC is met in the PEEP parameter in this instance. Okay, so let's look at an example. Here we have a worksheet where the daily minimum values have been documented across the calendar days, and we want to observe to see if the patient at any point has a period of stability or improvement, immediately followed by evidence of worsening oxygenation. And we'll note that we do have a period of stability that can be observed in both the PEEP and the FiO2 parameters. However, note that it's not necessary to have it in both parameters. Just so happens in this example it was that way. The next step would be, following that observance of stability, do we have a period of worsening oxygenation? And in this example, there is an increase over the baseline period in the peak parameter greater than 3 centimeters, which satisfies the requirement for the VAC definition. The increase must be sustained for 2 days, which it is, and it must be in reference to both days of the baseline period, which it is. So we meet the VAC definition. Before we move on, though, I want to step back and look at the FiO2 parameter to highlight why the VAC definition was not met in that FiO2 parameter. We do have a period of stability, as I mentioned, and we do have an increase in reference to the period of stability on day 4. But again, this is another example where it was not sustained, and so the VAC definition was not met in the FiO2 parameter. And again, I want to point out that it's not necessary to meet the VAC definition in both parameters. You're only looking for it in one or the other parameter. Getting back to our example, the event date is day 4, and event date is defined as the first day of worsening oxygenation. The date of the onset of worsening oxygenation is the date of event. It's not the date with all VAE criteria are met, and it's not the date of the first day of the baseline period. The earliest date of event for VAE in mechanical ventilation is day 3, and the first possible day that the full VAC criteria can be fulfilled is mechanical ventilation day 4. So why is the event date so important? Well, for one thing, it defines the VAE window period, which we're going to cover shortly. And this is the period when all the other criteria that are needed to meet either IVAC or PVAC must be met. And then secondly, it sets the 14-day VAE event period. Each VAE is 14 days in duration, and that 14 days was just arbitrarily set for standardization. Day 1 is the event date. So if June 1st is the day of onset of worsening oxygenation, and the VAC is reported, a second VAE cannot be detected or reported until June 15th. During that VAE event period, you cannot upgrade. So if you only met the VAC definition, and that's your VAE day 1, but later on you seem to have met another VAC definition, and within that 14-day period you now meet IVAC, you don't upgrade. You just stick with your initial VAC determination, and the VAC within the 14-day event period is not reported. You may not report a new VAE until the 14-day period is elapsed, and blood cultures that are determined to be secondary to a VAE must also occur within this 14-day event period. The VAE window period is the period of days that I mentioned around the event, and that's where all the other elements that are used to meet IVAC or PVAC must occur. It's usually a 5-day window period, and it includes the 2 days before, the day of, and the 2 days after the VAE event date. So let's take a look at this in a picture. So at the event date, the day of onset of worsening oxygenation is mechanical ventilation day 13. The VAE window includes the 2 days before, 11 and 12, and the 2 days after, 14 and 15. And again, this is when all other criteria used to meet IVAC and PVAC must occur in order for to progress on in the algorithm. As with everything, though, there is an exception, and that is in which the VAE window period is only 3 or 4 days, as follows. In cases where the VAE event date corresponds to either mechanical ventilation day 3 or 4, the window period described above may only be a 3 or 4 day window because it cannot include any days before the 3rd day of mechanical ventilation. So the patient's not eligible for a VAE on days 1 and 2, so you can't use those days to meet a IVAC or PVAC definition. Again, let's look at this in picture. So remember, again, that you can't have eligibility in the first 2 days of mechanical ventilation. So in this example, the event date is the 3rd day of mechanical ventilation. So your VAE event date on this representation is limited to 3 days. Your VAE window is limited to 3 days. Your event date is day 3. You can't use the 2 days before because the patient was not eligible for VAE surveillance, but you can use the 2 days after. So let's go back to our original example we were working on. If we say VAE window day if we say the VAE window is the day of event, the 2 days before, and the 2 days after, what's wrong with the picture here? Excuse me. Well, what's wrong is that the VAE window period needs to be shortened to 4 days. In this case, we can only use 1 day before and 2 days after. Okay, now that we have the first tier mastered, I'm sure you all are just right on board. Let's move to the second tier, IVAC. To satisfy the IVAC definition, which is the infection-related Ventilator Associated Complication, you must first have met the VAC definition, and then in addition to that, you must have either an abnormal temperature or white count, and the patient must have been started on a new antimicrobial agent that was continued for greater than or equal to 4 days, keeping in mind that those things have to occur within the VAE window period. Snapshot of the protocol outlining the IVAC definition. Take a look at the first step of reaching IVAC, and that is your abnormal temperature or white count. Here, going back to our example, we have the the window highlighted, VAE window highlighted, and you can see that in multiple instances we have met an abnormal temperature or abnormal white count as defined in the surveillance protocol. And as long as there is an abnormal temperature within that VAE window period, it is to be used in determining whether the patient meets the IVAC definition or not, regardless of whether the temperature or the white blood cell count was also present on admission or present outside the VAE window period. So if the temperature is detected present with the VAE window period, they can be used to meet the IVAC definition, and that is true. If you're conducting in-plan VAE surveillance in your ICU, when will you need to assess daily minimum and maximum temperatures? For all the patients that are ventilated, only those who have been determined to meet VAC definition. Those who have been determined to meet the VAC definition also have an abnormal white count. Patients who the clinical care providers have diagnosed with VAC. And the answer is only those who have been determined to meet the VAC definition. So if you haven't met the VAC definition, don't waste your time running around gathering temps, white counts, antimicrobial agents administered, or laboratory data. The second criterion of the IVAC definition is probably the most complicated portion of the VAE surveillance definition algorithm. The rules for meeting this criterion are not perfect, but we needed to standardize the method. It mostly consists of antibacterials, antifungals, and some antivirals. There are some exclusions, as noted on the slide. And it originally was a broad range of agents that could be used to treat healthcare-associated infections, not just respiratory-related infections. There was some concern with this approach when it resulted in meeting the PVAP definition, but the antimicrobial agent was not used to treat a respiratory infection. And we tried to address this, not 100%, but to avoid increasing the complexity of the IVAC antimicrobial list, was refined and selected antimicrobial agents that would not be used or would be likely to be used in treating a lower respiratory tract infection in a critically ill patient were removed. That being said, figuring out if an agent is a new antimicrobial agent, it's defined as an agent listed in the appendix that was initiated on or after the third calendar day of mechanical ventilation and in the VAE window. So the agent is not considered new for purposes of this definition. It is not given to the patient on either of the 2 days preceding the current start date. The new agent must be continued for 4 days or equal to 4 days. And there's no requirement that the agent be given on the same agent be given on the 4 consecutive days. The agent must be administered either IV, IM, via the digestive tract or the respiratory tract. Figuring out if there's greater than 4 days of therapy, and that's been given the name of Qualifying Antimicrobial Day, and this is a day on which the patient was administered an antimicrobial agent that was determined to be new within the VAE window period. 4 of these QADs are needed or more to meet the IVAC criterion, starting within the VAE window period. So days between administration of new antimicrobial agents also count as QADs as long as there's a gap of no more than 1 calendar day. And so in this example, levofloxacin was administered every other day, and the days in between count as qualifying antimicrobial days. In contrast, when it's a different agent, the gap between agents does not count. And so in this example, while we have 2 QADs contributed by the levofloxacin, and then the agent is changed to meropenem, that day in between does not count as a QAD, and so therefore in this example, the greater than or equal to 4 QAD requirement is not met. Excuse me, back to our example, we have met the VAC definition, we have abnormal temp and white count, and we also, for simplistic sake here, I'm just signifying that we have an antimicrobial agent that was started in the VAE window period. It was new, and it was continued for greater than or equal to 4 days. So that meets the IVAC definition. A question that we get often is, do you count an antimicrobial agent as new if it's new as a result of de-escalation or simply a switch from one agent to another in the same drug class? And the answer is yes. And this is just to avoid more substantial complexity to the antimicrobial agent determination. So we are not making exceptions for de-escalation, switches to other agents in the same class, or narrowing of spectrum. When evaluating patient data to see if the IVAC definition is met, you should focus only on antibiotics that are used to treat respiratory infections, and that answer is false. Although we've refined the antimicrobial agent list that's used for meeting the IVAC definition, it's still possible that an existing agent may have dual purposes and not necessarily be treating a respiratory infection, but it still will count towards the qualifying antimicrobial days. Finally, the third tier of the definition, the PVAP definition. This is the final tier, and it's referred to as PVAP or possible VAP. Patients who have met the VAC and IVAC definitions and additionally have laboratory evidence of respiratory tract infection then can be determined to meet the PVAP definition. We are looking at whether they meet purulent secretions definition, whether they have eligible cultures or other positive laboratory evidence. The PVAP definition can only be entertained if VAC and IVAC are met, and the laboratory test collection dates must occur again in that VAE window period. The organism exclusions must be considered, and one of the following criteria must be met. Snapshot from the protocol. 1 by 1, the criterion 1 is a positive culture of one of the following specimens meeting quantitative or semi-quantitative thresholds as outlined in the protocol. And to meet criterion 1, there is no requirement for meeting the purulent respiratory secretion definition. How do you relate your lab semi-quantitative culture reporting to the quantitative thresholds? Well, first of all, ask your laboratorian if they can give you some equivalents, and if not, similar to what I discussed earlier with the pneumonia definition, a report of moderate or heavy growth, or 2+, 3+, or 4+ growth is determined to meet the criterion 1 requirement for the PVAP surveillance definition. To meet the criterion 2 of PVAP, in this example, because there's no quantitation of a pathogen that is necessary, you can just simply have a report of just Staph aureus without a quantifier such as many or few. In this instance, to meet criterion 2, you do need to meet the purulent respiratory secretion definition and a positive culture that doesn't meet the quantity that is required for meeting criterion 1. When you're looking at the meeting purulent respiratory secretions, again, if your laboratory doesn't quantitate neutrophils giving a greater than or equal to result for neutrophils or a less than or equal to 10 for squamous epithelial cells, then ask your laboratorian if they can interpret to provide you equivalents, and if not, there is guidance on how to correlate your laboratory's reporting method to the purulent respiratory secretion quantitative definition in Table 2, and this is Table 2. So there's some clinical laboratories use different result reporting formats, and so we didn't want to tie you just to be able to meet the definition using that greater than or equal to 25 and less than or equal to 10. Criterion 3, which is the least used criterion for meeting PVAP, just requires that one of the following positive tests are found: pleural fluid culture positive without a quantitation, lung histopathology result indicating that there is a pathogen present, a diagnostic test for Legionella, or a diagnostic test on respiratory secretions for influenza, respiratory syncytial virus, adenovirus, or parainfluenza virus, rhinovirus, or human metapneumovirus, or coronavirus. So that's our virus listing. For histopathology lung results, what we're looking for is the formation of a foci of consolidation with intense neutrophil accumulation in bronchioles or alveoli, and you'll find these results under your pathology section of your laboratory reporting. Evidence of lung parenchyma invasion by fungi, hyphae, pseudohyphae, or yeast forms, or evidence of viral infections, and this it will be a cytology result. Additionally, non-culture-based results will satisfy the PVAP definition. The pathogens listed here, Legionella and selected viruses, may be detected using antigen testing, PCR, direct fluorescent antibody testing, sometimes referred to as DFA, or serology. And do note that there are some pathogens that are not included. For example, mycoplasma or chlamydia are not part of meeting the PVAP definition. Pathogen reporting is limited to PVAP, and you'll enter that into NHSN similar to how you report for all other events. And a reminder that pathogens are not reported for VAC or IVAC. Question we get frequently is, what does the Candida species or yeast not otherwise specified, coagulase negative staph species or enterococcus species refer to? And this slide just spells out exactly what we're talking about. All Candida species, those that have been identified to the species level, such as Candida albicans, those that are reported just as Candida species, or simply a result that reports many yeast isolated. Similarly, for coagulase negative staph, staph epidermidis, for example, would not be an eligible pathogen. A report of just staph species would not be an eligible pathogen. What if I have a BAL culture similar to this, normal flora with many Pseudomonas and moderate Candida? Can I use the report to meet criterion 1? And the answer is yes. An eligible pathogen accompanied by an ineligible pathogen may be used to satisfy the PVAP criteria. And note that the report is not a quantitative report. However, many quantity is acceptable as a semi-quantitative equivalent. So let's go back to our example. Here we have an example of how the criterion 1 can be met. We have a eligible specimen, an endotracheal aspirate with a quantity that is meeting the positive quantitative threshold of 10 to the 5th with an eligible pathogen of Staph aureus. Here's an example of how you can meet the criterion 2. In this example, it is an endotracheal aspirate, and the gram stain is signifying that the purulent respiratory secretion definition is met, and we have a quantity of an unnamed quantity of a pathogen, Staph aureus. So it's not going to meet the criterion 1, but along with the purulent respiratory secretions definition, it will satisfy criterion 2.
And finally, an example of meeting the PVAP criterion number 3 with a pleural fluid culture. And note, the pathogen is Candida albicans. If you remember with the exclusions of the pathogens, they are not acceptable pathogens unless isolated from pleural fluid or lung tissue. Those are sterile sites, and anything isolated from those specimen types should be considered a pathogen. Okay, with this, I think we're running over time. I don't know, should I continue on, folks, or do you want me to cut it short and we'll pick up where we left off at the next session?
Cindy, why don't we go ahead and cut it short if you want to take another minute to wrap anything up. I know we probably lost, a substantial part of the audience, so it'd be good probably, I think, if we just pick up and start another time. We'll get the message out to the audience to let them know when that'll be in the future.
Okay.
You need another minute or so?
Yeah, let me just advance through here to a couple of slides just to get you going on. So if you're preparing to conduct VAE surveillance, what you want to do is, one, you want to definitely read the protocol a number of times. You want to establish relationships with your respiratory therapy or critical care colleagues. Share the protocol. They're going to be invaluable to you. Also, determine your laboratory's approach to gram stain and culturing report. And then you want to prepare to how you're going to organize your data. Explore the tools that are available. We have provided worksheets on the VAE webpage that will be useful for you for data collection. You want to be reminded that when you're conducting in-plan VAE surveillance, you must report all events. You can't decide, I'm only going to report PVAPs or I'm only going to look for VACs. And that there is a hierarchy. If the patient meets VAC and IVAC, you report it as IVAC. If the patient meets VAC, IVAC, and PVAP, you report it as PVAP. Some more tips for getting started. I just want to point out that there are, along with the protocol on the webpage, there are also additional FAQs posted under the FAQ section. Lots of answers to some frequently asked questions as it relates to the VAE protocol. And then finally, do experiment with the VAE calculator. Not only is it helpful in making your determinations, it's also a good educational tool. And with that, I'll wrap it up and allow for any questions that anybody may have, and we'll pick it up and finish with case studies and the calculator in another session.
Thank you, Cindy, so much for that really detailed and really a lot of great information. I know the QIOs and the hospitals will really appreciate it. I think since we're over and we're really going down all the time the things, we may skip the questions, but we do have the link in there for anybody that has any questions to submit them to the NHSN help desk because we've got allowed on there. So I hope that will be okay with you, Cindy.
Sure, that's fine.
And we will work for the rest of the audience. We'll work with Cindy because we know there'll be at least a part 2 of this. Some of you may not actually be reporting to NHSN yet, so this is a good introduction. And in a few more months, when some of that happens, we will certainly bring Cindy back to us so she can take us through the rest of this. We thank you so much for joining. And again, thanks, Cindy, and have a great day. Thank you.